So presenting Mrs. P, who is a 43-year-old housewife from Dhanbad. She's a known case of hypothyroidism for the past 1 year, has no other significant past history, has now come in with complaints of weight loss of 18 kilos over the last 5 months, abdominal distension, dyspepsia, and loss of appetite for the last 3 months, and low-grade fever, which was intermittent with evening rise of temperature for the past 2 months. On examination, her weight was 56 kg, BMI of 22.4. Vitals, she was stable. She was noted to have pallor, a right axillary firm mobile lymph node, which was 0.5 centimeter, an umbilical nodule, which was palpable, and system examination showed dullness in the right infrascapular region with absent breath sound, suggestive of a right pleural effusion. And per abdomen, there was distended with full flanks and shifting dullness, suggestive of ascites. Rest of the system examination was normal. So coming to the syndrome and differentials in her, she presented with systemic symptoms, lymphadenopathy, an umbilical nodule, a right pleural effusion, and ascites. So our initial differentials considered in her would be a disseminated malignancy, probable GI or ovarian primary, or a disseminated tuberculosis, or HIV with an opportunistic infection like TB or atypical mycobacterium. So coming to the initial investigations, her hemoglobin was 9.73 with normal total counts, platelet of 3.4, normal renal function, BBVS was negative. Her CA was 1.66, CA 99 was 3.5, and CA 125 was 42, all within normal limits. We went ahead with a cross-sectional imaging for her, which showed hyperdense lesions with peripheral ring enhancement in the right parietal lobe, suggestive of metastasis, parenchymal and fissural nodules in bilateral lungs, suggestive of metastasis, soft tissue deposit in the body of the gallbladder, mild right pleural effusion, peritoneal metastasis with enlarged mesenteric lymph nodes, enhancing soft tissue nodule in the umbilical region, and soft tissue deposits in the right adnexa and uterus. So from the history examination and the imaging part, we were thinking more in terms of a malignancy with metastasis in her. We went ahead with a biopsy from the cervical lymph node, and that showed well-formed, discrete and confluent granulomas composed of aggregates of epithelial histiocytes, small lymphocytes, Langerhans cells, and MNGs, with suspicious foci of necrosis and occasional AFP positive, but expert NMZ on the tissue sample was negative. We also went ahead and did a biopsy from the umbilical nodule, which also showed granulomatous inflammation with necrosis. Again, expert MZ was negative on her. So I just wanted to focus on Sister Mary Joseph nodule and pseudo Sister Mary Joseph nodule in this presentation. Sister Mary Joseph nodule is classically defined as a palpable nodule bulging into the umbilicus as a result of metastasis from a malignant cancer in the pelvis or the abdomen. This is first described in 1864 by Sister Mary Joseph, who was a surgical assistant to Dr. William James Mayo. She is the first one who noticed the association between abdominopelvic malignancies and a hard umbilical nodule while preparing patients prior to surgery. So the umbilical, it's usually an umbilical or a paraumbilical nodule, firm in consistency, 5 to 15 centimeters in size, may be associated with pain and can have serous mucinous or bloody discharge from it. What is the pathology? Yet the etiology is still unclear, but the proposed mechanisms are a direct extension of the tumor into the umbilicus, hematogenous or a lymphatic spread, and direct extension. The fourth one is through the remnants of vitellointestinal duct or through your falciform ligaments, spread of malignancy or infection. So coming to the differentials of a Sister Mary Joseph nodule, 38% of them is caused by a primary tumor, 30% by a secondary metastasis, and 32% is seen in endometriosis. And considering the metastasis, 20% is from stomach, 14% from large bowel, 14% from ovary, 11% from pancreas, and no identified primary in 20% of the cases. Coming to pseudo Sister Mary Joseph nodule is when you have a Mary Joseph nodule, but it's not because of malignancy. So this is one case study that was published in BMJ in 2019, where they have described a similar patient, 46-year-old woman with no comorbidities, who came in with 3-month history of weight loss, abdominal distension, vomiting. Imaging showed multiple lymphadenopathy inside the abdomen, had an umbilical nodule palpable. Biopsy of the umbilical nodule ruled out a malignancy. They didn't have a definitive diagnosis for TB as such, but they started her on ATT and she resolved with ATT. The umbilical nodule disappeared and clinically also she improved. So this is the only paper that I could find regarding a documented pseudo Mary Joseph nodule in TB. Coming to our patient, we started her on ATT with DEXA because she had parietal lobe involvement also. We started her on April 2024. 1 month review, we noted that she had gained 1 kg weight. She was symptomatically better, no further fever spikes, and the umbilical nodule had come down to 2 into 2 mm. At 2 month review, she completed her intensive phase. She had good response, weight gain again of 1 more kilogram, and the umbilical nodule had fully disappeared. So just wanted to focus on thinking of other differentials when you have a Mary Joseph nodule.
Thank you, Dr. Krupa. Just a question. Why do we add DEXA to that ETT?
She had CNS TB also, sir.
Oh, she had CNS?
Yeah, she had imaging was showing hypodense lesion in the right parietal lobe.
Any questions from the floor? No questions. I just wanted to stress this thing of, because clinically you are pretty sure that she is going to go to gynae, right?
Yes.
But it turns out that, you know, all these imaging and biopsy did help. But I think it's important to recognize that whenever we ask for an investigation, I think generally what we do is like, you know, abdominal pain. That's all we have for that clinical,
data.
You know, data. So I think if you give more, and if you just tell them abdominal pain with query CA ovary, so this is the report you get. I'm just looking at the report, you know, you won't have a second thought as to whether this is or is not a CA ovary, for instance. So I think it depends on how much we tell the radiologist about the clinical situation of the patient. And of course, a couple of DDs, rather than just saying CA ovary, just approve that kind of thing. So I think that's very important whenever we ask for any imaging for that matter. The more information you give a radiologist, the better report we get. So always remember to write what you think when you ask for imaging. And same thing with biopsy, because unless we come together, and it's always good to have a team meeting, the end of the whole thing, be a learning experience for all the specialties for that. Thank you, Dr. Krupa. We'll move on. So Dr. Ritesh from Medicine 5, GELID.